introduce our speakers for the first portion of our webinar today. Elizabeth Gilstrom is a Senior Research Scientist in the Public Health Practice Section, Health Partnerships Division of the Minnesota Department of Health. Trained as an epidemiologist, she has extensive experience working with state and local public health data. Previously, Dr. Gilstrom worked in the MDH Center for Health Statistics with a focus on maternal and child health research. She has been the principal investigator or co-PI of several public health services and systems research studies and staffs the Minnesota Public Health Practice-Based Research Network. She will be joined by Rebecca Pratt, who is a faculty member in the Department of Family Medicine and Community Health at the University of Minnesota. Dr. Pratt is a community psychologist and works in the area of public health approaches to mental health. She has extensive experience in conducting qualitative and mixed methods work in health services research. Her work explores making important linkages between qualitative and quantitative data sets, which offers an important contribution to work that considers both the process change, the impact of interventions, and the interactions between both process and outcome-oriented data. Dr. Pratt is an expert and trainer in NVivo 10 software to facilitate qualitative data analysis and has additional expertise in the areas of health disparities, multimorbidity, and complexity. So with no further conversation for me, I'm going to hand the reins over to Beth and Rebecca.
Great, thanks, Anna. I am going to start things off. This is Beth Gilstrom, and greetings from Minnesota, where it is actually pretty sunny and nice today. We'd like to talk with you today about local public health and primary care collaboration, which has really been rooted in a practice-based approach. First, I'd like to acknowledge the Robert Wood Johnson Foundation. We are a grantee, as Anna had said, of a previous Public Health Services and Systems Research National Program, but also want to acknowledge the local public health directors, local medical clinic directors and staff who have participated in our interviews and surveys, as well as all of those who've really been key in our practice-based research networks and have provided implementation guidance. So just a little background, certainly we're all, I think, pretty familiar with the 2012 IOM report on integrating primary care and public health. When we first set off on this project, we really didn't find a lot of information about the degree to which public health and primary care work together at the local level, yet recognize that there is increasing pressure on both public health and primary care to collaborate, and really these increased expectations for efficiency and effectiveness of services and population health improvement. We were curious, though, about what might be some barriers to system integration, as well as while collaboration sounds great, it can also be challenging. So to that end, we decided to create our own collaborative, which for us has been a real strength of this study in terms of pulling together practice-based research networks from both the primary care and public health sectors to work on the study and really lead it and be the study advisory committee, but also had 4 states. So while this is being led out of Minnesota, we have some really fantastic co-investigators from Washington State, Colorado, and Wisconsin. So just wanted to acknowledge all of that effort. So as you'll see with our little diagram, we had a multi-phase of this study. So the first was a qualitative phase where we conducted paired interviews in the 4 states with 40 local public health and primary care respondents. We also did a much broader survey and again engaging primary care and public health leaders, but really tried to get as many jurisdictions as we could across the 4 states. And really at this point we are now trying to meld our key findings both from the qualitative and quantitative results, hoping to take some of this dialogue and some of what we're learning and really translate it into some action steps. So starting off, we had these kind of key research questions, and I, right off the bat, want to draw attention to one of our first early learnings, and that is that integration is not really a beloved term on either the primary care or public health side. Tricky for us in terms of as we present on it, though, because all of our research questions were really couched using that phrase. But what we were really trying to get at is looking for variation across our local jurisdictions in this either degree of integration or our more preferred term of collaboration between primary care and public health. What barriers are out there and which of those may be most problematic? Does the perspective matter? What does primary care think versus what does public health think? Where are there similarities and where are there differences? And then, really, are there some action steps that could be taken to really promote this collaboration and overcome barriers and really focusing on keeping it grounded in a practice-based perspective? So as I noted with the survey implementation, we had a sample that was drawn from 241 local health department jurisdictions. So we used the local health department entity to define the jurisdiction. In some instances, we oversampled on the primary care side, so had multiple respondents identified within a jurisdiction to try to increase that response rate. And actually one of the, I think, secondary benefits of that approach for our primary care folks is that there was not necessarily universal practice-based research network coverage in each state on the primary care side. And so our primary care investigators in the other states really put a lot of time and effort into trying to identify clinic leaders in those jurisdictions where they didn't already have these relationships, which I think has had this secondary benefit of really increasing their potential reach in their states. I should probably give a shout out to Wisconsin, who really went the extra mile on that piece. But that's really what comes into, as you look at these response rates, why we have both an overall response rate for primary care, but also a geographic specifics. That really gets at in which jurisdictions did we have a primary care respondent. And so although our overall response rate was about 31%, we did have about 50% of all of those jurisdictions represented by a primary care representative. Our survey itself was about 38 items. It was an online survey and very parallel, but really looking at these collaboration factors from both perspectives. So in terms of our methods, we did a lot of frequency distributions just looking at the public health and primary care data sets separately, but we were also able to create dyads where we had at least one representative from within each jurisdiction. There ended up being about 71 dyads, which is about 29 or 30% of that overall set of jurisdictions. So we looked a lot at percent agreement and the correlation of responses between the respondents within each dyad. And then we also used the public health, the primary care, and the dyad data sets to give you a little teaser here, to place jurisdictions within a multidimensional model of integration. We'll get back to that. So when I talk about this multidimensional model, which is coming soon, what we really started to notice is that there may be kind of two buckets of features or characteristics that seem important to these partnerships, which we are calling foundational and energizing. And so we went through quite a process to assign questions to those two buckets and create values and use them to create scores to really be able to position our jurisdictions within this new emerging framework. Just a quick shot of kind of who this sample ended up being in terms of when we're thinking about these jurisdictions. I just wanted to draw your attention first on that upper line. When we look at our full set of potential jurisdictions, we're looking to see, okay, well, how well does the public health only, the primary care only, or the dyad seem to reflect that full set of potential jurisdictions? And we see that, our primary care only really was more focused in larger population areas, and then our public health only does seem to line up perhaps a little bit more closely to our full set. So that's something that we've been thinking about as we think about, okay, well, which data set is, the right one to use? Maybe there isn't a right one, but certainly something that we are thinking about. So in terms of some of the things we've learned both from the qualitative and quantitative data, as I alluded to, some of these aspects of partnership really are building and maintaining a foundation. Some of these activities, though, seem more action-oriented or energizing, and we don't necessarily see that whether you're doing something necessarily correlates with how satisfied you are with that relationship. Overall, it seemed like most respondents felt like, collaboration is important, but we're starting to feel that this relationship is probably not a linear relationship, and that as we're thinking about our model, that it's perhaps a little bit more dynamic, and it may be that jurisdictions move in and out, or these relationships move in and out of these relationship quadrants. So we're starting to really think about these collaborations on this two-dimensional model. So on your lower left would be those that they're relatively weak with regard to both foundational characteristics and with energizing characteristics. So they maybe aren't coming together that frequently on projects or even on clients. They don't have any sustainability features in terms of staffing or financial commitment. They also really lack formal structures. And then this idea of, that you hear a lot in partnership literature about, do you have a shared vision, trust, respect, and value? Those elements aren't necessarily there. On that lower right-hand corner would represent partnerships that are stronger on the foundation, so they may have those shared vision, trust, respect, might have some supportive leadership, but they may not actually be doing any tangible work together. So they may say, oh yeah, we think primary care, public health is great. Of course we want to work together. We very much value and respect those opinions, but there isn't really much going on. In that upper left-hand corner would be really the converse of that. They haven't necessarily invested in those things that we've seen in the literature build relationships, but they might come together on a specific client to address a crisis. They may have some features in place that allow them to work together and some leadership that actually directs the work. Finally, that upper right-hand quadrant is really where they pull it all together, and they've got both foundational and energizing aspects of the relationship. And so we were really curious to see, okay, well, what happens when we create these scores? Where do our jurisdictions fall? And so in each of these quadrants, the top line is using our public health only data. The second line is using the primary care only data. And the third line is if we use our dyads to try to place these jurisdictions. And you'll see there's a fair amount of variation in where they land depending on who's responding. With public health, I think, being more optimistic, perhaps, than primary care's view of the world. So that raises some questions of, well, boy, we're seeing a fair amount of variation. And so, it's making us think, well, which picture do we take? And I don't know that there necessarily is a right picture. One of the things we did note is that when you look at the public health only, when we asked this group to self-rate their degree of working together, it's pretty close in terms of that highest quartile of work and what they say whether they're working together consistently or not. And as I think about, too, that more of our primary care representatives are coming from a larger geographic area, it may be harder for them to speak to that overall relationship because they may not have that bird's eye view of the whole jurisdiction in the same way that a local health department would. And they also have a more variation in roles represented. But I kind of think that the distribution probably falls somewhere in between, and probably is, as we're seeing, is somewhat dynamic. It may be changing, and I would hate to suggest that we would discount either perspective, because I think both perspectives are really important and valuable if we're going to be promoting the work. So I just wanted to give a quick snapshot of some of the quadrant characteristics associated just with this public health data set. So this is the larger sample size. To me, it's a little bit interesting that when you look at whether or not the health department is a standalone or versus a within agency structure, those that seem to have the lowest energy or the lowest amount of working together are those that are in a combined agency, as opposed to being in a standalone. And then also to draw your attention, when you look at the jurisdiction type, that low energy but high, or low foundation but high energy, there doesn't seem to be as big of a difference between whether it's a single or a multi-county. They're pretty relatively distributed between the two. And we just have a couple more characteristics as well. Another thing that jumped out to me was when you look at that high foundation and high energy group, they are the most likely to report either a very consistent working relationship across all of their clinics or kind of a generally the same. So we asked our public health respondents, how do you actually work with your clinics? Does it vary a lot? And so it was very interesting to me that those that seem to be in that highest quadrant seem relatively consistent within their jurisdictions as well. So I'm now going to turn it over to Dr. Pratt to talk about barriers.
Thank you. So as we are thinking about this framework and the ways in which energizing and foundational characteristics might interact to influence the way in which folks might come together to collaborate, we understand that there might be a bird's eye view and that people might be able to use this framework to think about how their relationship is formed in general. People have also given us a lot of positive feedback about the potential value of that framework approach to thinking about the ways in which they may even come together around particular topics or activities or projects. So we've had a lot of really encouraging feedback as we've been consulting with the potential user community about this framework. But invariably, a question that always arises as we talk about the framework, and it's a wonderful question, is how do people move from one part of this framework to the other? What would help somebody in their partnership move from being in one of the less active, low foundational areas into having more solid foundation and more directed action in their relationship? And in that leads us to the question of what gets in the way when people are stuck somewhere they're not hoping to be. What kind of barriers do they need to overcome to really elevate their work and build their relationship towards greater collaboration? So what we'd like to do is just talk about some of the key barriers that we have observed. One of the things I'll note about the qualitative piece of this work is we really, and I think this is a distinguishing feature of this project, is we engaged people who had a wide variety of relationships. People who might be working very closely together and well, or those folks that we might know as the exemplars in the field. And I think they characterize a lot of what we see in published work on this topic. So we decided to search a little bit more broadly and engage people whose relationships also might be less well-formed or have kind of challenges, to ask them too about what gets in the way. So some of the barriers that people raised with us were very much related to aspects of the partnership that they had with each other. Communication emerged as a really common barrier, finding ways in which to be able to communicate and share with each other across public health and primary care. And in some ways, I think that the increasing emphasis on having electronic health records and great health-related IT systems puts this into sharper irony for sites that even though there might be greater technology, there's no way to make that talk between the two partners. And that can be a real frustration. Very closely related to that are challenges around being able to share data. and being able to share information together. And as you'll have noticed from our framework, that being able to come together around shared data and information for the purpose of thinking about how to prioritise action together is very important. So it's not surprising to us that where that data is hard to share and the communication is difficult, it forms a real barrier. A lack of a prior partnership is an issue, as is that lack of developing a shared priority. There's nothing like a data-driven shared priority to really focus action. And so that lack of shared priorities is really a tremendous barrier when people are thinking about how to come together for better collaboration. And I think one of the things that emerged quite clearly from our data is that a key barrier to forming a partnership is not understanding each other. And I couldn't emphasise enough how much of a barrier that can be. And I think for both fields, primary care and public health, there's a real sense of the fields being going through a tremendous amount of change and evolution right now. So maybe it can be challenging to understand ourselves. But really taking the time to fully understand what each partner brings to the table, their skills and knowledge, was a significant barrier as described by some of our partners. Now, if I move on to the next slide, you'll see that really a second kind of type of barrier emerged, and we are referring to those as system-related barriers. And that constant change that I just mentioned features quite large as a barrier in there, because it's very difficult when navigating a lot of change within your own field to then work out how you define that relationship with a different field. And both public health and primary care are undergoing quite a lot of change in their own right. That not only makes it hard to understand each other, but it can lead to a little bit of a fatigue in terms of dealing with finding the energy to make further changes and build relationships. The funding environment was mentioned as an issue, and some folks face what we've termed geographic challenges in terms of the areas that they physically serve. So a public health department might provide coverage across a very large geographic area, and that can come with a certain number of challenges for building the relationship. Many of the barriers, and both primary care and public health articulated this very clearly, related to the primary care context. And for an example, we have a quote there talking about the fact that you may have primary care relationships as public health, but you might be dealing with 3 different electronic health records just in the one small area. So that system can be quite fragmented. Primary care is under a unique level of strain in terms of productivity, and a unusually sharp sense of change being underway with health reform. Primary care is sort of under siege, as it were, at the moment, and both public health and primary care are very sensitised to that being a barrier. Resources emerged as an issue, but certainly not the only issue. Resources are not surprising to be mentioned as an issue. And both public health and primary care talked about the need for systems change to help improve working relationships. Now, as we